All right. Thank you, Deputy Secretary Moran, Deputy Secretary Lord. Thank you very much for the comments. We're going to move on right now because we're going to move to the kind of the legislative portion of the event. And we have a few legislators here that are going to kind of share some of the things that they're working on this year that we're really excited about. First, I'm going to invite up Senator Hettleman. So Senator Shelly Hettleman represents District 11 in Baltimore County. She's a member of the Budget and Taxation Committee in the Senate, and she's the lead sponsor this year of a bill to expand mental health training for coaches at public schools and universities, and a longtime sponsor of legislation that's been a priority for the Maryland Behavioral Health Coalition, authorizing the establishment of overdose prevention sites, which is a key harm reduction strategy in the state. So, Senator Hettleman.
Thank you so much, Dan. Good to see everyone today, and thank you to my colleagues for indulging me. I have to get in and out to introduce some constituents before the Executive Nominations Committee, so I really appreciate the opportunity to be here today and to talk about some of those bills. First, I have partnered with Chair Pena-Melnick for a number of years now, as well as one of my predecessor in the House, Dr. Dan Morheim, who sponsored a bill to create overdose prevention sites. And I had the opportunity to go to New York last year with advocates, with Chair Pena-Melnick, and to actually see in New York what they're doing and the incredible work that they're doing on the ground there. You all know, and we all know, that since 2020, Maryland has lost nearly 7,500 lives to overdose. In 2022 alone, over 2,400 Marylanders died of a drug overdose. And these aren't just numbers and statistics. They are people, and they are dying, in my view, preventable deaths. These alarming rates of overdose deaths are clear indicators that people who use drugs are not receiving all of the care that they need. What we have done, and I know you are doing a tremendous amount of work, and this administration is too, but we all need to use all available tools, and ones that are evidence-based and have been known to work, employing a multifaceted, multi-pronged approach that will save lives. We have done important work here, broadening access to treatment, reining in the provision of prescription opioids, launching educational programs in our schools, expanding access to naloxone, as well as medication-assisted treatment, which was, I applaud this administration for going after that waiver, and I'm wholeheartedly in support of it. And we could be doing more, and that's what this bill would do. This bill is not a mandate, it is not a directive, it enables local communities to decide what is best for them. Under this bill, if a community organization, a hospital, a local health department, a federally qualified healthcare center, or a substance use treatment center, for example, wanted to offer an overdose prevention site, they would work with their local health department and apply for approval to the Department of Health and get permission to operate. The bill would create a pilot program in non-residential areas, 2 urban, 2 suburban, and 2 rural sites. Substance users would be permitted to bring their own pre-obtained substances and use under the care and supervision of healthcare professionals. A variety of services would be offered at these sites: wound care, substance use disorder education, housing counseling, HIV testing, etc. There have been over 100 peer-reviewed studies that have supported the efficacy of overdose prevention sites. They point to isolated drug use increasing the risk of fatal overdose significantly because there is no one there to save someone. OPS brings people out of isolation and saves lives. In fact, in areas with OPS, there are reductions in use and increases in treatment. What is evidence-based and has been proven to be effective in decreasing substance abuse should be driving our policy decisions. What we were doing hasn't been enough, and what we must consider in light of the persistence of the devastation of overdose deaths is a new and data-driven approach. They are not a panacea, but they are another very, very important tool that will help us to address this crisis that continues to take so many lives. I'd like to talk to you about another bill that I've been working on. It is mental health training for coaches. And this bill speaks directly to the work of the Mental Health Association of Maryland. We know that 1 in 5 children and adolescents suffer with mental health problems. And as you know, these mental health conditions come with real consequences later in life and in their current lives, impacting physical health and limiting opportunities. And despite the seriousness of this problem, almost 2/3 of young people are not getting the help that they need. And young adults are at particularly high risk need. This is a transitional period. It is a stressful developmental stage of their lives, now accompanied with concerns about climate change, gun violence, rising costs of goods and services, and all of the complicating arena of social media. And despite the efforts of universities and colleges to provide more comprehensive mental health to their students, 2/3 of college students have not accessed these campus resources. And student athletes are not immune to this issue. A recent report found that 1 in 4 student athletes are at risk of depression. This bill is a needed step towards making mental health care more accessible for this at-risk group. The bill requires the Maryland State Department of Education and the Maryland Higher Education Commission, in collaboration with partners, to develop guidelines for public schools and higher education institutions to train coaches to recognize indicators of mental illness and behavioral distress in students. And it presents a new mechanism to reach student athletes who may be struggling but are not being reached by existing mental health resources in schools. And coaches, as many people in this room who may have been student athletes know, and parents know, they often serve as trusted figures for student athletes who spend lots of time with students outside of formal academic settings. And they're uniquely qualified to identify, well, they need to be trained to identify warning signs and connect their athletes with the needed services. Not necessarily to provide them, because they're not the experts, but to know where to go when they see them in their students. The resources can serve as a new and different way to monitor student well-being more broadly. These adolescents and young adults deserve high-quality, accessible mental health services and support from the adults in their lives who can connect them to the help they need. Though coaches are highly motivated to serve in this role, and 67% of coaches surveys want training on mental health, only 18% felt highly confident in their ability to link athletes to mental health resources, according to this national survey of coaches from the Aspen Institute. We know we have to do more to support coaches and others, but this bill focuses on the one group that often serve as lifelines for our student athletes so that no one is left behind. And this bill advances that important goal, and we're grateful for all of your tireless efforts and the advocacy of MHA-MD around these issues. Thank you so much.
Thank you, Senator Hettleman, for championing those efforts. Look forward to supporting them this year and continue supporting them this year. So next, I'm going to bring up Delegate Jessica Feldmark from District 12A in Howard County. Delegate Feldmark is a member of the Ways and Means Committee, and she is the lead sponsor this year of critical legislation that will provide stable and sustainable funding for Maryland's 988 Suicide Prevention and Behavioral Health Crisis Lifeline. So thank you, Delegate Feldmark, and welcome.
Thank you. Good afternoon. It is great to see so many people coming out to focus on legislative priorities to support mental health this legislative session. So let me start off by just saying thank you to all of you. I'm Delegate Jessica Feldmark. I represent District 12A in Howard County, and I am proud to be the lead sponsor of House Bill 933, which will dedicate an ongoing funding source for 988. We've done tremendous work with getting 988 stood up and making sure it was funded for the first few years. Now, I don't know if anyone has heard about this budget challenge we're facing this year. So what's really important is making sure that we have dedicated funding for 988 so that when we are in tighter budget years, you all don't have to focus all your energy on fighting for funding for 988. You can continue focusing on the important advances we're hearing about in the other legislation that I'm so proud to have colleagues who are sponsoring. So this is about making sure that when someone has the motivation to reach out, that we capture them and get them the appropriate care when they're ready to receive it, okay? I met with some constituents from NAMI the other day, and they shared, this was one of the bills that they're focused on, so we had a great conversation about it, but they shared some data about 988 volume comparing from May of 2022 to May of 2023. So call volume increased by over 40%. Web chat volume increased by over 50%. These are huge increases. But wait for it, text volume increased by over 900%. Now, I am, I'll say of an age, but I'll just say of a mindset, right? Where the idea of having like a difficult, emotional, vulnerable conversation via text is so not my preferred mode, right? But we know that for a whole generation of native texters, right, that is, that's really important to be able to meet people where they are, right? To be able to provide help in the mode in which people are ready to receive it and ready to reach out and ask for it. And so, you know, this is about making sure that, because this growth, right, we're gonna continue to see. So as awareness increases and willingness to reach out increases, we need to make sure that we are fully staffed, right, to respond, to answer the call, answer the text when it comes in. So I think that having a dedicated revenue source really just sets the foundation so that we can make sure we're able to respond. And I'm very proud to say that I have bipartisan support in my co-sponsorship on this bill. Now, that's a great thing for any bill, but especially a bill that is setting a fee, right? I mean, I've been saying dedicated revenue source, which is lovely language, right? We're talking about putting a fee on phone bills, right? 25 cents a month, $3 a year, right? A really nominal fee to pay to make sure that when you or a loved one needs to reach out in crisis, someone is there to answer with the appropriate care at the appropriate time. And so to have bipartisan support on a fee bill is a really strong indication that people understand and appreciate and support the importance of 988, and we need to make sure that it's secure for the future. So thank you very much.
All right, thank you, Delegate Feldmark. And one more, we have one more legislator to bring up before we move on to the actually share the youth premiere of our Youth Voices video, which we're really excited for. So our champion, Delegate Bagnall, is at it again this year. She's the lead sponsor this year of legislation to strengthen health insurer parity compliance reporting standards and enhance the MIA's Parity Enforcement Authority. She's also lead sponsor of legislation streamlining accreditation of residential treatment centers. But also, and she's not the sponsor of this legislation, but she is very respectfully and compassionately managing efforts related to one of the most contentious and challenging policy topics in the behavioral health community, and that's assisted outpatient treatment. We don't shy away from controversy here at the Mental Health Association of Maryland. So this is a debate that has raged for decades with well-meaning folks on both sides of the issue. And last session, when her chair asked Delegate Bagnall to lead a process with advocates and her legislative colleagues, she worked tirelessly to address everyone's concerns and develop a somewhat consensus product that actually passed the House but didn't get out of the Senate in time. And she has been tasked with doing this again this year. And it is a Herculean task that's going to be fraught with issues and contention throughout. But if anyone is up to the task, I know she is. And so, Delegate Bagnall, you want to come up and say a few words about what you're working on?
Thank you very much. And you remember that earlier theme, it takes time? This is the demonstration of that. I'm about to get really clinical about something that is really personal. But when I was asked to speak briefly on assisted outpatient treatment, I thought, how am I going to do that? This is the legislation we've been reckoning with for over 2 decades. And despite the tremendous recent investment in our behavioral health system, we still have people who fall through the cracks or end up in the criminal justice system rather than in treatment. So what is assisted outpatient treatment? Well, according to the Treatment Advocacy Center, assisted outpatient treatment, or AOT, is the practice of providing community-based mental health treatment under civil court commitment as a means of, 1, motivating an adult with mental illness who struggles with voluntary treatment adherence to engage fully with their treatment plan, and 2, focusing the attention of treatment providers on the need to work diligently to keep the person engaged in effective treatment. At its core, AOT is an intervention tool for those with serious and persistent mental illness, which results in an inability to maintain or even recognize their illness, to allow family members and friends to petition the court before someone decompensates to the point of the crisis standard, dangerous to self or others. It's for people who cycle through our ERs and the criminal justice system, who often end up homeless, in jail, or dead. It's a practice which has been adopted in 47 states and is designed to be adaptive to the needs of the states in which it is implemented. And I will admit, when the bill first came before our committee, I was extremely skeptical because of all the things that weren't defined in the legislation, and the very real concerns being raised by multiple stakeholders. What were the civil rights protections? Who was responsible for implementation? How would we ensure that Marylanders even had access to the services necessary for their treatment? How would this nexus with existing programs? What resources would be brought to bear? And who was accountable at the end of the day? The Department of Health used the work group and the consensus language of the work group. But I was to get those answers last session because, as Dan Martin said, the chair of our committee established an AOT work group, and I became the chair of that work group. Our charge was to bring stakeholders together and find a compromise which would give us a meaningful tool to aid in the overall wellness of our Maryland citizens. From crossover to sine die, a group of dedicated legislators and stakeholders, including the Mental Health Association of Maryland, Maryland NAMI, On Our Own Maryland, the Treatment Advocacy Center, the Maryland Judiciary, and the Office of the Public Defenders met multiple times per week and went line by line and concern by concern to find a workable compromise. I will admit, as the weeks went on, there were days when everyone would stand up and say, our committee is not meeting today, our subcommittee is not meeting today, and I would stand up and say, the AOT work group will be meeting at 8:30 a.m. on Zoom. My apologies. But this was a group that really wanted to make sure that we struck the necessary balance. And so everyone showed up day after day without complaint and getting donuts and coffee in the committee room. By sine die, everyone had given something. Everyone had gotten something. We all acknowledged this wasn't the solution to our mental health challenges, but would be a meaningful tool in the fight. The bill that passed the House ran out of time in the Senate, and that bill, House Bill 832, is the framework for the governor's bill. So what's in the bill from last year, and how is it different? Well, one of the priorities of the work group was striking that balance, ensuring resources were brought to bear. It was really important to me, that was really important to our members, that we were ensuring civil rights were protected, and that we were ensuring that voluntary treatment was an option. Working with the Mental Health Association of Maryland and our other stakeholders, we established a petition and court process which ensured all civil protections afforded to anyone in a civil or criminal proceeding. That any jurisdiction which opted to participate in AOT provided a care coordination team with case management or assertive community treatment, if clinically recommended, and peer-to-peer services. We made sure that those who wished to enter voluntarily would have that option to do so, and created a process whereby if the treatment plan changed and all parties agreed, the court could be notified without a hearing. Additionally, to address concerns of stigmatization, criminalization, and weaponizing health care, the records of AOT are sealed. The Department of Health used the work group and the consensus language of the work group for the framework of the bill this year. So what is the most significant change? Well, that it's the governor's bill, because the governor is investing in a statewide crisis system, so the bill will ensure AOT is available in every jurisdiction with centralized coordination, so every Marylander can be sure that their family will be entitled to the same access and protections regardless of zip code. We have continued this collaboration even as the department proposed changes to ensure we maintain the very essential compromise language and court processes. And I want to thank the Mental Health Association of Maryland, oh my gosh, the Lieutenant Governor's gonna make me cry, for your continued advocacy and for being a willing partner in the crafting of this essential legislation. We know this isn't gonna help everyone, but it's gonna help someone. And if that someone is your brother, your sister, your friend, your family, you will no longer have to stand by and just watch them get sicker and sicker while knowing that there's nothing you can do. Because now you're gonna have something that you can do, and you can be assured that your family member or your friend, that their civil rights will still be protected under this legislation. So I hope that we will all have you helping us make sure that we pass the best bill to protect and also help our Maryland families dealing with persistent and severe mental illness. Thank you.